Welcome back to our medical case series, where we explore intriguing patient scenarios and unravel the mysteries behind their conditions. Today, we delve into the ICU, where an interesting case awaits us. So, let's jump right in. It was a bustling day in the intensive care unit, with patients requiring immediate attention. The unit chief had begun the rounds, starting with a newly admitted case of diabetic ketoacidosis. The discussion surrounding the patient was uneventful. Next up, the junior resident stepped forward to present a fascinating case that had everyone's attention. The patient in question was a 50-year-old male, previously undiagnosed with diabetes and a HbA1c level of 10. Let's hear the rest of the story. 7 days ago, the patient arrived at the emergency department complaining of a fever for 2 days, a productive cough for 2 days, and rapidly worsening shortness of breath. His oxygen saturation was alarmingly low at 80 on room air. Clinical suspicion pointed towards community acquired pneumonia, which was later confirmed by a chest X-ray. At admission, he had no renal injury. The medical team promptly initiated treatment, including antibiotics and oxygen supplementation, leading to gradual improvement. Unfortunately, as his condition improved, new challenges emerged. The patient developed acquired pneumonia caused by Acinetobacter, a troublesome bacterium requiring a potent antibiotic called polymyxin B. Despite the complexity, the patient responded well to the therapy. Now, at this critical juncture, the junior resident sought approval from the unit chief to step the patient down to the general ward. However, the unit chief noticed an interesting finding. The patient's urobag was full with a significant urine volume of 3.5 liters. This raised a red flag and prompted further investigation. On the left, you can see the urine flow rate of our patient, while on the right, the normal urine flow rate is shown. It's clear that our patient had rapid flow rate. The resident diligently charted the patient's urine output over the past 5 days, revealing a consistent pattern of increased urine production, known as polyuria, a condition in which the 24-hour urine output is more than 3 liters per day. Polyuria is a symptom that warrants a closer look at kidney function. To determine the cause of this excessive urine output, a comprehensive evaluation is needed. We will pause a bit and review some basic sciences and get back to the patient. The kidneys receive approximately 20% of the cardiac output per minute, which corresponds to around 1,000 milliliters of blood or 600 milliliters of plasma. Within the kidneys, filtration occurs, and approximately 600 milliliter of plasma is filtered by the glomeruli each minute, resulting in the production of approximately 125 milliliter of glomerular filtrate per minute or 180 liters per day. In the proximal convoluted tubule PCT, about 70% of the water, along with solutes such as sodium, glucose, and bicarbonate, is reabsorbed osmotically. As a result, the urine remains isosmolar to the serum. As the filtrate reaches the descending limb of the loop of Henle, about 20% of the water is reabsorbed into the interstitium through the osmotic gradient created by the countercurrent mechanism. No solute transport occurs at this point, leading to an increase in urine osmolality, making it hypersmolar. The ascending limb of the loop of Henle is impermeable to water but actively transports sodium, potassium, and chloride ions into the interstitium through the sodium-potassium chloride cotransporter. This process makes the osmolality of glomerular filtrate to fall. Finally, at the collecting duct, the reabsorption of water is controlled by antidiuretic hormone ADH, depending on the osmolality, hydration, of the serum. AD increases water reabsorption, resulting in concentrated urine. The final urine osmolality depends on the absorption at the collecting ducts. Regulated by ADH, normal urine osmolality is highly variable and ranges from 500 to 800 mosm per liter. On average, The tubules reabsorb 99% of the glomerular filtration rate GFR, and only 1.8 liters per day are excreted as urine. A subtle decrease in reabsorption from 99% to 98% can lead to significant electrolyte and hypovolemia issues. We will have a quick review of osmolality. Approximately 50 to 60% of an average adult's body weight is composed of water. For instance, in the case of an adult male weighing 70 kilograms, his body would contain about 42 liters of water. Out of these 42 liters, approximately 2/3, 28 liters, is located in the intracellular space, while the remaining 1/3, 14 liters, is present in the extracellular space. Within the extracellular space, 2/3 of the fluid, 10.5 liters, is distributed as interstitial fluid, which surrounds the cells, while the remaining 1/3 is the intravascular plasma. The movement of fluid between these compartments is regulated by osmolality, which refers to the concentration of solutes in a solution. It is important to note that the osmolality of the extracellular fluid is more prone to changes due to factors such as fluid intake, oral, IV, or dehydration. Any alterations in the osmolality of the ECF can subsequently affect the osmolality of other compartments as well. Normal serum osmolality ranges from 275 to 290 MOSM per liter. What happens when there's a change in osmolality? For any change in osmolality, it's the water that freely diffuses across ICF and ECF to compensate. The solutes cannot move freely across membrane. When the ECF osmolality increases, fluid from ICF shifts out to compensate, which causes the cell to shrink. When ECF osmolality falls, water moves into the ICF to compensate. This causes cellular edema, but these changes are acute. With time, the compensatory mechanism that come to play the most significant role is the ADH secretion. ADH, antidiuretic hormone, is secreted from the supraoptic and paraventricular nucleus in posterior pituitary. ADH secretion is primarily regulated by the serum osmolality, which in turn is dependent on changes in serum sodium and water content. Any increase in serum osmolality is sensed by the osmoreceptors in pituitary, which then increases ADH secretion and triggers thirst. ADH increases free water reabsorption through two mechanisms. 1. Increases the free water absorption in collecting ducts through two receptors. 2. H also increases urea reabsorption, which diffuses into the medullary interstitium and causes rise in interstitial osmotic gradient, thus concentrating the urine. The added free water brings the serum osmolality back to normal. Having understood the physiology, we will now give you the patient's clinical and lab details. Please comment down your differential diagnosis. That has been it for this video. See you in the next part. Don't forget to like, share, and subscribe to our channel for more medical content like this one.